Oh, hi, Dr. Tennant.
How you doing, everybody? Merry
Really
Christmas.
well. How are you doing? Merry
Yes.
Christmas.
Thank you.
Yeah.
Hope your Christmas was good so far.
Always good. I always got all those gifts for a man who has everything and needs nothing. So,
That's awesome.
I now got to find some place to do with all these things I got. So anyway, I had a great Christmas. Good Christmas for the night on the show. So
Good. It's the last episode of 2024, but we're starting a brand new season in a brand new year. And I thought back on the past year of what we've been through and the different things that have happened, both good, bad, and ugly. And I think we've come a pretty long way. It's been a distance, that's for sure.
I think we made great progress this year. Frankly, behind the scenes, I guess. But no, from my vantage point, I don't know how we've done more.
I agree. I think it's been a
So,
great journey. It's been a really great mission. And from something we thought might have been one or two shows, here we are, since October 15th of 2022. We're going into 2025. How in the world time flew like that?
one of the best things that may have happened this year is that we've developed kind of a community for the first time in the country that's trying to help people who have, intractable pain, arachnoiditis, Ehlers Danlos, Epstein-Barr, the unpopular diseases, and yet we've got a group of people and a number in the thousands now who are with us and who are trying and coming up with better ideas every day.
Absolutely.
We got Mark there too. Good. Yeah.
Yep.
You all right?
Good. Dr. Ibsen's here. Yay. So good to see you. Merry Christmas.
Thank you. I'm driving, so I'll be listening mostly.
Yes, be careful, please. Just go ahead and give a warm welcome, a warm Merry Christmas to everyone. We're looking forward to all brand new things.
Jimmy, thank you very much. I want to welcome everybody here to the last show of the year. Thanks to everyone who has contributed. I'll say a few more words about that near the end of the show. This is a great day in some ways. In fact, we're going to have a little bit of, you might say, some Christmas gifts to the community of tragic pain victims. And we're going to start out tonight with something that probably never heard of. The announcement I want to first make tonight is that this year, a very talented Hollywood producer who produces documentary and whose name is Andrew Abrahams has produced a documentary with the title Complicated. This was instigated primarily by a family out of New Jersey, Donna Sullivan. And what this is about children with Ehlers-Danlos syndrome. It was instigated because a lot of parents were accused of child abuse, of all things, because their child ended up in school or somewhere with bruises and scrapes and what have you, and the nurses and the school people and what have you had no idea that these kids had joints that would dislocate, that they would fall, that they would get ill. And so it looked like it was abuse when it was really a terrible disease. And so they contacted Andrew, and Andrew's company is called Open Eye Pictures. He's, to those of us who follow Hollywood and documentaries, he's well known. He is the person who really popularized Lyme disease with his documentaries about Lyme disease. And so he was a top gun to publicize, if you will, Ehlers-Danlos syndrome. And the movie is called Documentary. Now, here's what the announcement's all about. He submitted this documentary to the Sundance Film Festival. Now, if you're not familiar with the Sundance Film Festival, this was Robert Redford's baby. who started it in Park City, Utah, and it's grown to where it's now big time. I used to ski there the first year they had it, and I think it was, I even went to some of the showings because it was just a couple of dozen people and some, off the wall producers who, those of us who were there and who appreciated that kind of thing. Now it's thousands. Believe it or not, 10,000 documentaries are submitted to Sundance Film Festival each year now. Only 144 are accepted, and so this one's been accepted. Now, I know it's going to be great. It's going to be a big hit because I'm in it. Not really, but I'm in it to talk about Eilers Danlos and Elvis Presley. Of course, you got to have a little pizzazz in Hollywood to get known, but I wanted to congratulate Donna Sullivan and particularly Andrew Abrahams for this acceptance and the fact that he's going to make Eilers Danlos. Could put it on the map. We're certainly going to get a lot of publicity out of this. And as all of you know who watch this, Eilers Danlos and its related diseases, the Marfans, the osteogenesis imperfecti, the dwarfism, some of these genetic conditions have just lead to terrible conditions. And so I wanted to make this as a good announcement. Second announcement I have, which is kind of interesting. You will recall we had in the last couple of weeks Dr. Solarian. And Dr. Solarian, of all things, wanted to bring up a subject which everybody talks about, but nobody does anything, and that's the dishonesty in government. Well, he decided to go out and have what he calls the world's first honesty day for February 15th. And I want you to know, apparently he's hit a nerve. I just received an email from him yesterday, and he says that their reception for Honesty Day on February 15th has been so great, they're going to now have it on 2 days. So I want all you government people to know out there that we've now got 2 days in which we're going to tell you you may not have been quite as honest as you thought you were. So anyway, congratulations, Dr. Solarian. Keep up the good work, and heaven knows we need a little honesty out there. The second thing I want to announce is that 2 days ago, Amazon and Kindle published my new handbook. And it's a little handbook written primarily for medical practitioners, but sophisticated patients and families can read it. And it's called Epstein-Barr virus. It's a handbook for testing and treatment of patients who have severe chronic pain. Okay. Now, it's not a long handbook. It's going to cost all of $10 or something. But we've had so many inquiries, particularly from the medical practitioners around the country and even the world. We've now heard from some 60 countries throughout the world. And anyway, these provide the guidelines for who you test and how to interpret the testing for Epstein-Barr virus. I hate to say it, and I hate to bring it up, but this is a little complicated. It's not as simple as just taking a blood sugar or a cholesterol level. This is more complicated. However, I think that anybody can learn it, and I think those of you who have Epstein-Barr virus entities are going to need to know some things about it. So on this show, and I'll tell you a little more about it even later, I'm going to try to bring up a little bit of education about the Epstein-Barr virus and the other viruses on the show. A little quick blurb going into this next year, because first off, my recommendation on who should be tested is pretty simple. If you've had chronic pain every day for over 90 days, to the point that you've got to take medication every day to relieve it, you need to have the Epstein-Barr virus test. And with a little good luck, your doctor might even test you for herpes 6 and COVID and Cytomegalovirus, because the Epstein-Barr virus tends to work in concert or in tandem with other viruses. I mean, I'm getting mail almost every day now in which somebody has COVID, long COVID, took the vaccine, and now that seems to have boosted or accelerated, if you will, their Epstein-Barr virus reactivation. Okay. Now, for the next few minutes, we're going to start taking some very basic lessons about testing and treatment for the Epstein-Barr virus. Okay. Now, when you, the way that works is this. The Epstein-Barr virus is something that inhabits all of us. And it's what's called a parasite. It's in our lymphocytes and it's in our membranes of our throat, maybe in our spleen. And everybody has this. And it's called a dormant, harmless parasite. So what happens? It turns out that under a severe, significant stress event, the virus can reactivate. In other words, it just starts over. It enters the bloodstream and it passes on the bloodstream into tissues like your arachnoid lining, your cauda equina, your glial cells in the brain, but also your fascia around your muscles. And that's why you end up with fibromyalgia. It gets into your cartilage and of the wrist. You get carpal tunnel syndrome. You can get Hashimoto. You can get irritable bowel. You can get headaches. In other words, the virus goes in the blood to a lot of different tissues and can cause not only a chronic pain condition because it degenerates the tissues, it can cause some cancers. So that's the way it works. A stress event, and that stress event can be trauma, it can be infection, it can be a psychological issue, but it can reactivate. But here's the thing I want everybody to know. There are two antibodies that primarily get formed when the virus reactivates. And one's called the viral capsid antibody, and you abbreviate that VCA. That's an abbreviation that pain patients need to know, VCA. It's on all the lab tests. Every laboratory now can do the test. All laboratories throughout the country have developed the test or contract to do the test because the Epstein-Barr virus problem is out there and medical practitioners are picking it up by the day. The second antibody you have is just called the Epstein-Barr nuclear antigen antibody, and it's abbreviated EBNA. So you've got two antibodies, VCA and EBNA. Now, these antibodies have a normal level, just like you have a normal glucose or a normal cholesterol or a normal red blood count. There's an upper normal limit. Now, when you get above that limit, that means that your infection has caused too many antibodies. And if you have chronic pain and you've got antibody levels at least 2 or more times normal, then you've got Epstein-Barr autoimmunity. And you've probably had Epstein-Barr invasion of your tissues. But the first thing I want you to know is everybody has to need those two antibodies measured, okay? Now, the second part of this little lecture is this. It's very confusing because the treatment or the control of the Epstein-Barr virus has three parts. One is prevention, and this is the step number one and the easy one. It turns out that there are a number of things such as vitamin C, zinc, selenium, lysine, luteolum, quercetin. There's a lot of curcumins in there, a lot of natural supplements that will prevent reactivation. So that everybody needs to be on those with the idea if you can stop the reactivation, then if there is live virus hanging around your body, that virus will die out. Now, the second thing that happens is that when the virus reactivates, it's just floating around in your system and it starts to duplicate, replicate, and it gets right in your tissues. And it can cause erosion, degeneration, fibrosis, scarring, and it can even kill off small nerve fibers. For example, one of the worst with the Epstein-Barr virus is pudendal neuropathies, burning feet, burning mouth, and small fiber neuropathies. And that's because the virus can actually kill off small nerve fibers. It can also kill off receptors in the brain. And so it's a serious problem. And thirdly, it develops what's called autoantibodies. For abbreviation, it's known as autoimmunity. Now, autoantibodies is our bane of our existence. Let me repeat that. Autoantibodies to the Epstein-Barr virus is really the bad guy. This is an unfortunate, tragic situation. Incidentally, these may be the same autoantibodies that we find in rheumatoid arthritis, systemic lupus, Sjogren syndrome, psoriasis, Crohn's disease, Hodgkin's disease, lymphomas. These autoantibodies all seem to be kind of related, and the nature of an autoantibody is to mistake normal tissue, thinking it's some outside organism or element that it needs to attack. Here's the catch. The autoantibodies don't go away. They remain for life, and they have to be suppressed and controlled. And this is where such drugs as corticosteroids and Toradol, and now we're getting some very positive reports on methotrexate and some other chloroquine, and some of your autoimmune medications are being used now for this. We've got a number of patients, both in Germany and here in the United States, that have adhesive arachnoiditis who are using these autoimmune medications, and they're getting positive. I'm getting positive reports. I'm very excited about that because we certainly need that. I won't go into it tonight. To determine if you have active virus in your body, then you're going to need the antivirals, some of your antiparasitics like ivermectin or chloroquine to combat that. So anyway, the book has these things in it. It can be easily followed by any physician, nurse practitioner, PA, psychologist, chiropractor, pharmacist. It's easy to understand, I think you'll find. A little complex, but nevertheless, we're getting started. What I want to do now is to shift gears to another educational subject. It turns out that I've now probably personally reviewed over 2,000 MRIs from persons with adhesive arachnoiditis and cautoequino inflammatory disease. And I have been suspicious for some time that we were not doing the correct exercises. Most of you have seen the publicity about all the unnecessary back surgeries in the country. And that tells me that we've often got a lot of people that are having back pain that aren't getting better, so they sit for the knife, even though they really shouldn't. And we have had for years a standard set of back exercises, which I could see in our patients weren't helping anybody. And then I had a couple of very bright orthopedists and some other physiotherapists consult with me about a belief they had, and I wasn't certain it was true, so I started comparing the MRI defects and with what patients were doing for exercises. And I have a major recommendation tonight for people with adhesive arachnoiditis or multiple spine defects, including multiple herniated discs. A major change in exercises that I'm personally now recommending to people. And here is what it is. It is now, this was brought to me, and I didn't believe it at first, but I've now looked at these x-rays and how the discs are damaged, how the spine is damaged, as well as the normal physiologic contour of the spine. And I now no longer recommend two things. People should not be laying down doing any exercises. And number two, the old stretch and hold exercises should not be done. And this applies mainly to people with adhesive arachnoiditis. Here's what I'm getting at. It turns out, and the reason why some of these experts brought this to my attention, and see how I believed it, and I studied it, and I agree with him now. And that is the normal alignment of the spine is only in place when you are standing. If you are sitting or if you are laying down and you try to exercise, you may actually harm yourself if you have adhesive arachnoiditis or a lot of multiple discs. You need to be standing straight up. And also, you are not to do what we used to do and what I used to preach. We now know it was not correct. And that's what's called stretch and hold. In other words, when you stretch your arms up like this, don't hold them. What we've been teaching people, hold them for 10 seconds, 20 seconds, 30 seconds. The answer is no. Just do this repeatedly, but do it while you're standing. Do your arms up like this. We love lifting some weights, 2 or 3 pounds. That's why one of the reasons why walking is so therapeutic. When you walk, you're standing straight up. And the spine has a curvature to it. And when you're standing straight up, you straighten it out to some extent and allow the spinal fluid to flow in its normal flow, coming down the spinal canal and then back up. And walking on a trampoline, dynamite exercises. And it turns out that, for example, what the old sway that you do, at parties or for your football game, the wave as they call it. In other words, it doesn't make it hardly a darn bit of difference what you're doing, but as long as you're standing there and you're doing some exercises with your arms or trying to bend over or lift weights. Bottom line, if you have adhesive arachnoiditis or a lot of multiple discs that have penetrated, slipping or herniated, don't do exercises laying down or on your side or sitting because you may actually harm something. And don't do what they call stretch and hold. If you go to a chiropractor or physical therapist, don't let them sit there on the table and stretch you if you have adhesive arachnoiditis. Massage, now you're talking. Lay down and get the massage, but don't do stretch and hold exercises if you have adhesive arachnoiditis or some other major spine disease. I'm going to be changing a lot of my written materials to recommend you do spine exercises standing, sort of like in military posture, looking straight ahead, and then move your arms and your legs, lift up your legs or your knees, but do it standing. You can't hurt yourself that way, and you'll get a good spinal fluid flow movement. Okay, I want to move on now to another bit of good Christmas news. I got a call from an old friend a few days ago from Kat. Her last name is impossible to pronounce, but Kat is a wonderful woman who's both a patient with arachnoiditis and also she's an attorney, and she's an officer in the Disability Foundation. And she and Ashley, another member of our community, as well as some other people, went to the Illinois legislature to see if they could get a advanced bill passed to protect patients and physicians who prescribe opioids. Based on what I can tell, it's the most advanced law in the country. It's been done to correct the unintended consequences of the 2016 CDC guidelines. And it's from what I can tell, is a wonderful thing. And I'm going to call them on in just a minute. But I'm going to just read you something here real quick. This is a press release from a Chicago paper in Springfield. And it says, Illinois senators passed a bill Wednesday to expand treatment to people suffering from chronic pain. States implemented policies in 2016 that severely restricted doctors from prescribing opioids, even though chronic pain patients needed them. House Bill 5373 will allow physicians to make prescriptions for controlled substances without strict limitations based on dosage amounts. And here's a quote from one of the senators. Doctors became reluctant to prescribe opioids to chronic pain patients for fear of being criminalized or losing their license, said Senator Laura Fine. As a result, patients with legitimate need for these drugs are at risk of self-medicating and putting their mental and physical health in jeopardy. Congratulations, Kat. Would you, Jimmy, would you bring her on? We'd like to hear from her on this great news.
Yes, sir. Thank you so much, Kat. Welcome to Doc Talks. Welcome back. We're happy to have you back with us.
Thank you all so much. It's so good to see you all. And I have to say, this was a labor of 3 years. It actually started with just me and Ashley approaching my representative. And 3 years later, we got the support of the Illinois chapter of the American College of Family Physicians, the AMA, the American Anesthesiologist Association, and our state medical society helped an awful lot. So it took a village, but we're very excited.
Kat, can you tell us what does it, can you give us some specifics as to what the bill actually says? And you might also say, why is it different from California or Texas or some other state? This is far more advanced and protective than those states. But can you be specific on how is the patient protected? How is the physician protected?
So we actually started from the position that I did not want to exempt people. For example, sickle cell, palliative, we wanted to include everybody. So this bill covers all chronic pain patients. It does not matter what your diagnosis is, and it covers any healthcare professional who's treating chronic pain. So that's one way that we think it's a little bit different than some of the advances made elsewhere.
Yeah, so it's any chronic pain patient, not just the intractable pain patient, but anybody. How do they have a definition of chronic pain?
We provided a definition, yes, as being a state of pain that persists for 90 days or more, 3 months.
3 months.
And that's anything 3 months or longer. Those medical professionals and their patients are protected by this bill.
Now, you use the word controlled substances, and most people focus on opioids, but controlled substances also includes the benzodiazepines, does it not? And like a Valium or a Xanax or a Soma, I mean, okay, it includes those also.
Yes, it does. This is actually an amendment to the Illinois Controlled Substances Act. And our overarching goal was to stop fishing expeditions. So we also made some administrative rulemaking changes to keep law enforcement out of our prescription monitoring program. So at this point, going forward, as of January, if you are law enforcement, regardless of what level you are, state, federal, etc., you have to have a court order or a judicial subpoena that shows that there is an active criminal investigation, and you have to show cause for that. You cannot say any longer, give me the top this many prescribers or the people who prescribe this much or this amount.
Was there discussion there in Illinois about this problem of law enforcement agencies have no medical consultants? They've never wanted medical consultants. They have no medical advisory board. They have nobody. In other words, they have taken the position that they really are the doctors. They really know more, and they've excluded and they've pejorativized, of course, and humiliated the medical profession every chance they got. Was there much discussion about this in the committees?
Yes, there was. And actually, we made a real effort to move away from any attempts to rely upon the 2016 CDC guidelines or bureaucratic efforts that are similar, and to move into a state where clinical judgment is what dictates what happens between a doctor and a patient, not a regulator or a bureaucrat. And the analogy I've made is I'm an attorney. I would find it very strange if a lot of doctors were suddenly regulating my profession. I'm not sure why I have any business regulating the medical profession.
How did law enforcement take this in the committees? Would they object to it? Did they feel that they might want to get something off their back?
So we had a couple of really good things happen there. The first thing is that the Illinois Sheriff's Association decided they weren't going to take an adversarial position. That was a big deal for us. And the second one is that we had a friend at the AMA who I owe a lot to, who thought that the smart thing to do is to have them fight amongst themselves rather than with us, which worked very well. So we were able to keep them out because they're debating with themselves who should have what power, but none of them have that power at this point going forward.
One of the things that struck me about this, and I'd like to hear Mark's opinion and Ashley's, and then maybe the best thing about this, I don't know of at any time that the American Medical Association or the anesthesiologists have come forward to back a bill like this. Now, we've had local medical societies back intractable pain laws, but I was a little shocked. In fact, the most shocking thing to me about this is the backing that those organizations gave you. The AMA, I mean, the anesthesiologists. I mean, I can pick up the anesthesiology newspaper, for example, and you've got a good contingency of those people who don't believe in opioids. And and they've kowtowed to the psychologists that it's a mental problem and what have you. How did you have to work to get these people to back you? I mean, you had 10 organizations backing you.
We had more than 10 organizations. We had 10 sponsors at the end of it.
Sponsors, I'm sorry.
From both parties. It was bipartisan and it passed unanimously in the House and the Senate. So that was veto proof. And that's a vote of confidence, we hope, so that we can set a precedent to let people know that pain is not political. It doesn't discriminate based on how you feel. It doesn't discriminate based on what I think. Pain is pain. It's a symptom of a condition.
I was so pleased again to see some of the anesthesiologists back you. I can tell you on my end, I hear from more and more anesthesiologists who, they've been the hardcore. We're going to put in pumps. We're going to do epidurals. We're going to do the procedures. But I find more and more of the anesthesiologists who are doing pain clinics are, they might be surprised in themselves. They're actually enjoying doing some of the medical part of it now. But they're coming around, a lot of them, to recognizing the need for oral opioids and benzodiazepines and dopamine agonists. Can you tell us anything about the dynamics in working with the anesthesiologist or the AMA? Again, the fact that they backed you, I hope is the trend, because we've not had their backing in the past.
The AMA did work hard on the Minnesota bill. I think they did submit letters on behalf of that bill to try to get that passed. So we kind of built upon that. And I approached their chief legal counsel just as a pain patient, just to kind of say, like, I'm sure you've probably heard from some of the doctors in your organization what's going on, but want you to sort of hear both sides of this. He was very receptive. And in terms of getting support, I know that it's different in every state. In Illinois, the issue is not that doctors didn't want to prescribe, it's that they were afraid. They knew what our policies were. They weren't naive. They weren't trying to be opioid sparing because they thought that was the clinical thing to do. I actually asked several doctors about this in the process, and they said, if it was up to me, I would do this, but my hands are tied. And that's a situation we thought we could rectify if we eliminated the climate of fear. And we also eliminated the morphine milligram equivalence guidelines from being utilized at any level in the state.
That's hallelujah. When the doctor said their hands were tied, were they tied, do you think, because of fear of their license, the medical board, DEA, or the insurance companies didn't like it, their hospital didn't like it, malpractice, or all the above? What did they? What can you tell us about why the doctors were reticent to prescribe?
Well, my pain doctor, for example, he inherited me from two other doctors. One I had for 15 years, who's an international expert on CRPS. He co-wrote the Budapest criteria. He did not want to really keep prescribing after a certain point. And the second person actually was targeted by a former county prosecutor who did give me the list of the top 10 medical providers and went after him. So he stopped prescribing altogether. So when I got to my third doctor, and nobody wants to have to go to a third doctor or more, he was scared, and he knew what his colleagues had been experiencing. It wasn't, just a thought. It was things that he had witnessed from other people. He also was audited last year at the beginning of the year and had they asked for records, but interestingly, the only records they wanted were for patients taking opioids and patients who are at or over 90 morphine milligram equivalents. Well, we do not use MME in Illinois going forward, but that was definitely what was being utilized, which is why, in addition to the legislation, we needed the administrative updates to stop the prescription monitoring program board from relying upon outdated rules or policies or guidance, say from organizations like, I don't know, the CDC.
Another thing that I'd like to have some in-depth discussion about, when you presented the bills and committees and heard from the different legislators, either privately or publicly, what do they think about chronic pain patients who take opioids? I mean, do they think they're a bunch of slovenly characters, addicts, or normal people? What's their attitude about the chronic pain patient?
I think the initial attitude was that pain patients don't need more than a certain amount of medicine, and that we were all getting our needs met, and that if any doctor were to be targeted for prosecution or license suspension, etc., that was because they did something wrong. However, I did testify last year, and we had a unanimous committee vote in the Human Services Committee. And I think the conversation has changed quite a bit since then. I think there is a growing understanding of the need for the medication and the fact that there is not a one-size-fits-all solution. There simply isn't. And to try to do that to a doctor or a patient is simply not right. And it's not real. And it is practicing medicine, in my opinion. It's just my opinion, but I do think it's practicing medicine for somebody who really isn't the person interacting with the patient. So it's a little odd to me.
Mm-hmm. I mean, do they think that the pain patient is just abusing their drugs? Do you think they are impaired? What do the legislators feel about the patients?
The questions that we got revolved around the issue of diversion primarily. So I obviously brought data with me, and I said, well, I'm looking at like DEA data here, and the diversion rate among our community is less than 1%. So you're talking about, millions of people who are being harmed. And I think you all should be willing to take that risk. It's a very minimal risk. And the risk of not acting in terms of protecting this community and the people who provide for our community, healthcare providers, is much worse because we had a serious fentanyl overdose crisis here. And I think we were able to tap into that a lot to emphasize this is a form of harm reduction. If you are a harm reductionist, it is not safe to tell patients overnight, I'm sorry, I'm just not willing to write this or that because I have a chart here that says it's too much.
Mm-hmm. One of the interesting things about timing here is that in the very week you get this signed, we have a great segment of the psychiatric profession saying that all patients who take on opioids or have opioid use disorder, you're impaired, you're non-functional, you're out of control, and that you're just plain bad. Now, this comes out the same week that you get this bill passed. How do we resolve this perception of a major component of the psychiatric profession feels that anybody who takes opioids chronically has opioid use disorder and is mentally ill? And here you've got that. What's your comment about this?
A lot of people ask questions about that. And when I first met with my representative to prepare my testimony, she warned me and my bill partner, Tom, you're going to come up against some stereotypes about you all. And, you know, the reason I want you there, the reason it's so important to make this, I think it was a 3-hour each way trip on an Amtrak that did not recline and was really not pleasant, is because you all are living proof that this is not true. You all can say what needs to be said. They have to look at you. They have to look you in the eyes and hear what you're saying and say, no, I just won't do that. And fortunately, our committee was not that discompassionate. They were willing to believe us when we spoke up and were testifying.
Yep. Might call in Ashley. Are you there, Dr. Ibsen? What kind of comments do we have for these? Okay, Ashley, you on there?
Do we have you, Ashley? Let's find her. There we go. Oh, there you are. All right. Welcome, Ashley.
I thought I was unmuted. I'm sorry. I'm here.
Good.
But congratulations to Kat and everybody involved. I know it's hard work getting to these people and getting them to listen. We were even working on, or have been working on, a federal level bill that I'm still trying to push out there and find sponsors for. I don't really have a whole lot to say about that, but I'll let you know if something happens. But I did come across something concerning today. Ohio, this is from the Federation of State Medical Boards. So on December 18th, there's a bill that passed the House and Senate, but the governor would like to line item veto a provision within this bill that would prohibit any health-related licensing board or the Department of Health from infringing upon medical free speech. Let's take this out. And pursuing or threatening to pursue any administrative or disciplinary action against a licensee for publicly or privately expressing a medical opinion that does not align with the opinions of the board or agency. To me, that's something we should be speaking out against before he gets a chance to. It's unbelievable.
Yeah, I'll start right now.
Yeah, please.
Good. Are we connecting here? Go ahead.
Yeah, keep going.
Oh, okay. Well, the rest of the bill, and I'm thinking this is related to COVID and that's where it comes, but of course it's broadened and can apply to anything. But the bill clarifies that the World Health Organization has no jurisdiction in the state and that no political subdivision should use state funding to implement any health policy guideline, mandate, recommendation, or rule issued by the WHO, including the prohibition of issuing a prescription for or dispensing of a drug, including an off-label drug. So that was passed by the House and Senate, and the governor would like to take out one of the lines that he doesn't like. just wanted to let everybody be aware of that.
Mark, you want to make a comment about that?
Well, I'd like to know, did Governor DeWine go to Case Western Reserve, Ohio State University? Which medical school did the governor attend? And
Good question.
which residency did they fulfill on? So the governor doesn't like something and he's going to veto it, but without the medical expertise to do so. And I think this raises a beautiful point that these conversations should not be occurring in the legislative realm. I mean, they already have, and we have to deal with it. But basically, these are controversies that should be addressed by the state medical board, as incompetent as many of them are, much less so than the legislature. I had bypass surgery at the vaunted Cleveland Clinic, and they followed the law when I was discharged from there and provided me with 28 5-milligram oxycodone tablets to last the rest of my life, apparently. And no matter what the Cleveland Clinic knows, they couldn't. They had no power to influence the law that says this is what you get, no soup for you, or basically a shot glass of soup for you. So I don't see that it's practical for a governor to be making medical decisions. But on the other hand, the governor gets to look at laws, and so we need to move the lawmaking out of the legislature and back into the medical boards where it belongs in terms of our expertise. We're the experts. Thank you, Governor DeWine, for your opinion, but it's only an opinion, and it doesn't have any medical value whatsoever.
Yeah, so if anybody lives in Ohio or if anybody can make a call, I don't know if we can change this or what, but it's recent and I wanted it to be known to everybody. I didn't want, I'm sorry to bring the negative, but possibly if we can do something about it, have at it.
Well, I would suggest that we consider a case against the governor for practicing medicine without a license.
Kat, do you have any thoughts as far you had the legal experience here? How would we approach that?
Do you think it might be possible to get some constituents from Ohio and set up a meeting? Because I know that we actually, when we weren't sure how our governor was going to come down, that was one of our plans here. And having worked with Maria Higginbotham and the Washington Medical Commission, they're great. They're fantastic. That's not legislation. That's just a medical commission. But one of the things I realized very quickly is that that's not across the board. Like, we don't even have an equivalent in Illinois. However, had we not had gubernatorial support, we would have had to do this anyway, because there needs to be changes in the administrative rulemaking. Some of the states are better in terms of actually letting the medical board do its job. Some of those medical boards have gotten packed, unfortunately, with people who have a certain agenda. We had one on our medical board, although we've managed to put that person in a place where they're not really looking at doctors anymore.
There's one other thing I'd like to say, Dr. Tennant, and that is, and I sent this to you last week, a podcast with the American Medical Association and 3 members of the Federation of State Medical Boards. And it was sort of vague, terminally vague, about whether or not the Federation of State Medical Boards is going to continue to recommend MME guidelines and that sort of thing. And at the end of it, they seem to say that they might be willing to let that stuff go also. So maybe there's some progress happening at the Federation of State Medical Board level.
Good. Let me just say this. Actually, I didn't know you were going to bring up the issue of restricting what doctors can say in public or in private, but it's a carry right over to this whole pain and issue, as well as maybe some other issues. In other words, what they've tried to do was to literally, in some ways, somebody could say, well, the way to deal with your cholesterol is to eat more fat each day. And they're trying to manipulate what can be said. And we do have sort of a movement to stack medical boards, DEA, law enforcement, with no one with a solid medical background, and to dictate what's to be done. My guess is a lot of this is economic. They're trying to cut costs, but some of it is just bias, it seems to me. But I do think that you bring up the other issue that is lurking out there, and that is trying to literally pass laws that physicians can't express their personal opinion that might just disagree with the mainstream. I mean, if we had that law back years ago, we wouldn't know what tuberculosis was, or we wouldn't know what Pasteur couldn't have done anything, and Addison couldn't have discovered Addison's disease. They need to know that throughout history, medicine discoveries, people are a little bit not informed. This recent pharmacologic development where it's on TV gives people the idea that medical advances only come out of pharmaceutical companies. Well, that's a very, very recent thing. In history, this was always done by some private doctor or nurse out in the hinterland. Hippocrates was not sponsored by the government. So you have to remember that medical discoveries have usually been necessity has been the mother of invention in almost all cases. And it was not done by the government, but by some practicing doctor or shaman out there in some maybe small town or some tribe that came up with a new idea. But they want to squelch that. And that's dangerous. Okay. So I'm glad you're bringing this issue to us. And let's make that a regular part of the program. Anybody who hears that there's some law, regulation to squelch private opinion, medical, we need to know about it, because we're going to end up hearing about it, because we've got too many people out there want to suppress pain treatment and what have you. So, well, again,
it happened to me, Dr. Tennant.
Oh yeah, tell us. Go ahead.
So I gave a presentation with the Cato Institute on December 3rd, and it was a very powerful and well-received talk and Brandy Stokes presented her symptom complex, and I commented about it, and Kate Nicholson and Ron Chapman were in on it too, and it was moderated by Dr. Jeffrey Singer from the Cato Institute. That was December 3rd. On December 6th, I received notice from the Board of Medicine that they were having a I said in that session. So within 3 days, yeah.
I'm sorry, you cut out, but if you could start back over with the Cato thing was on December 3rd and then on December 6th, please. Thank you.
Yeah, on December 6th, the board filed a case against me for speaking out and being somewhat critical of the board. So there is a free speech issue, and it was timely and related, and more will be revealed as I get my attorney to let me speak more about it. But it's current, and it happened to me just this month.
Tragic. That's all I can say is tragic that that the ability of any government agency to squelch a adverse medical opinion just has to be tackled. And we have to know that that is going on. For example, this last week, the psychiatry profession has published their opinion, or at least one group of psychiatrists, that everybody who takes opioids for pain is impaired, out of control, can't stop their medicines and is fundamentally either a drag or a threat on society. Now, people watching this show don't agree with that. I don't agree with it. You don't agree with it. All of us know people who function very well with their opioids, and they hardly have a disorder and they're hardly out of control. But on the other hand, I wouldn't want to squelch their ability to say that, because then they could squelch the ability of me to say that a lot of people can take opioids even at high dosages and function very well, and it function better, in fact, than they could without them. So we want to be very careful that we also anyway, bottom line actually is you brought it to our attention. I'm delighted you have. Let's focus on that also in our future advocacy efforts here.
I had one quick thing, if it's okay. The Washington Medical Commission let me know that the state medical societies, not the ones that are overseeing licensure, but the private ones, actually work together. So they knew what was going on in Illinois without me even telling them. They knew what the problem person's name was, etc. That has actually been really helpful in terms of collaboration. And I would encourage people to tap into their local medical societies and to encourage that collaboration. And we did update our guidance to be conforming to the 2024 FSMB guidelines. So we are making those changes, but I think other states are partnering to do that. And I think that might be another way we can address some of the things that, for example, Ashley mentioned in Ohio and that are going on in other states.
Yeah. Oh, thank you for that. Go for it. Go to Washington. Go to Idaho. Go to Vermont. Go wherever they'll take you, Kat. Again, thank everybody for being here on the show tonight, as well as in the past. We've had a great year, both in research, in education, advocacy. I think we're making some great headway, and we'll continue to do so next year. To close out, just a couple of announcements. We're going to continue right on with this show next year. No changes. Same personality, same people. Let's bring some others in. Frankly, I can't think of a better use of our foundation's money than some of the efforts we're doing. One little change that I'm personally going to do, my moniker for education and research purposes has been Adhesive Arachnoiditis research and education, and our mission has been to bring diagnosis and treatment to every community. I'm going to modify that a little bit, that our name is now going to, of the project is going to be the Arachnoiditis and Epstein-Barr virus study project, but the mission is the same, to bring diagnosis and treatment to every community throughout this world. I'm shocked myself, but my foundation in this last year has received inquiries on how to help people from, would you believe, 60 countries on this planet? And that includes our adversaries in Iran, Russia, Korea, and places like this. So it does show that trying to help people can cross a lot of political lines, and helping people is still our goal, at least for a lot of us out there. Again, we've had a great year. Jamie, thank you so much for developing this show. So I'm going to sign off by saying, Jamie, we love you. We're so happy with what you've done. Again, Kat, congratulations. Ashley, Donna, Doc Clement, everybody, it's been great. Well, we'll see you next year, and we'll have a better year yet. Good night.
Thank you. We love you too, Doc. Thank you so very much.
Thank you, Dr. Tennant.
Every one of you.
So blessed.
God bless
Every
us,
week.
everyone.
God bless you all.
Thank you.
God bless you all.
Thank you, Ashley.
Thank you, Dr.
Great show.
You're not alone.
Jamie,
Thank you,
yes.
Jamie, and all your helpers.
Is,
God bless you.
can I say something here?
Yes, sir. Could we have Dr. Norm go ahead and say something, please?
I want to let Dr. Ibsen know we made those changes
Yes, sir.
and additions in the last article that we wrote, that
Yes,
he
sir.
and indicated changed some names, and so I got that corrected.
All right.
Also, is Marissa Hanson Marissa?
in the building. Let me look for you just a
She
second.
is?
I don't see a Marissa
Okay.
in here tonight.
Well, tomorrow I'm releasing a great article on her.
All right. All right.
And
It
so
sounds great.
it's
So
in yours.
everybody,
Yeah,
yeah.
it's in within she's gonna be within the norms.
All right.
It's called Opioid Crisis. Marissa Hanson, The Human Cost, A Voice of Systemic Failure, How DEA/pharmacists and the pharmacy profession has failed American paying healthcare.
Wow.
Beautiful.
Amazing. That's
So
beautiful.
I think I wrote an article, put an article together, and
Okay.
Dr. Ibsen reviewed it, and
Okay.
he said, "Get that thing down." You know what the
Oh.
hell? Well, don't embarrass me like that.
Well,
I-
you know, we love your work. We appreciate it a lot. And
You're the best, Norm.
thank you.
You're
Yeah,
the
you
best.
are. Thanks for
Well,
putting
thank you.
everything
Thank
out there that you do. And everybody, please remember Dr. Tennant's newest handbook. He's always putting out some awesome material as well.
Thank you.
So he's got his newest handbook out. So we love to support each other, as you can see. And thank you all for making this happen. Thank you, Dr. Ibsen, for doing this while you're driving. I mean, you guys are incredible. Thank you, Ashley and Kat and every person that was here. I cannot wait to see you all next year. And until then, God bless us, everyone. Thank you so much. Good night.
God bless you, Jamie.
Thanks, Norm.
You
This
for-
is the
All
first
right.
time in my life I've been within the norms.
Oh well, no, I've had you in there several on several occasions. Just take a look, but I this one, you know, you again are we're the foundation of this particular article and highlighting the absurd discrepancies in terms of pain, and also I want people to listen to the podcast notes. When you hit that button, there's a button that goes in, it gives you a lecture, and so listen to that.
Well, the governor.
Ashley, and thank you so much for what you've been doing. Okay?
No, thank you, Norm.
Oh my God, you need to come to Florida and talk with the Florida Board of Pharmacy, you and Kat, and I'm gonna leave it alone because I'm gonna start talking. And
I know
can't
we can
stop.
talk forever, but
Yeah.
Kat's doing her thing. I'm doing mine. We kind of collaborate here and
Thank
there.
you much.
We're
Thank
trying.
you so much for what you're doing.
No, thank you
Yes.
too. I use your articles often to share with these people, so keep them coming.
Oh, I am.
Please do. Ira, you got your hand up, brother. Feel free. Here we go.
I'll just say that this is time well spent. I wait a week to be able to hear Dr. Tennant speak. I liked it. I must say I liked it also when there was an opportunity to have some an interchange, to ask a question and having a little bit of a communication. I miss that. But today, I just have to say that today I found out that the blood work that I had done last week shows that I have Epstein-Barr, and that I never knew it. I had never known it. So my doctor, my primary, was also, you know, curious about the connection between the two, and
Amazing.
so you know, we learn a lot. With the opportunity to learn is open to everybody, professional as well as patients. And just thank you for the work that you do. And I'm going to keep looking forward to getting on and maybe even getting more involved in some way. Thank you very much.
Thank you, Ira. That'd be great. Every season has been a little different. So we thank you for your suggestions. And we just look forward to another year, another season, and more great things. Through a lot of bad things this year. But if I look back overall, the good things did outweigh the bad. So we have that.
Yeah.
All right. Sending you all kinds of love. God bless you all, each and every one of you. And see you next year.
All right. Thank you.
Bye.
Bye. Love you all.
Okay.
Bye.
God
Bye.
bless.